the class procedure subdivided into the preoperative evaluation, intraoperative quality control, and postoperative care. So firstly, I'd like to carefully select the patient and to make the patient more safe during the surgery. So preoperatively, we want to lowering down LP from the super high level to acceptable level. So basically, we'll be within 30 millimeter mercury. So in China, we believe that the ethnicity is different, especially for East Asian people. The anterior segment is quite different compared to people from other regions. So we have to be very careful about the potential PAS or even the iris incarceration after class surgery. So preoperatively, I will routinely use UBM or gonioscopy to evaluate the gonial structure, to exclude any lesions or narrow or PAS already happened over there. And then we move on to the intraoperative care. Firstly, we just open the conjunctiva. And in China, many people, I witnessed that many people have very thick subconch tendons capsule. So for those patients, I'd like to remove some of the capsule. And then we will create scleral flap. Actually, scleral flap will be created enough in size. Okay, here we recommend routinely use 5 and 5 millimeter in size, and thickness about 1/3 to 1/2. This is also commonly used for NPDS surgeries, and this is basically adequate for the further creation of the scleral lake. And then we can move on to the creation using carbon dioxide to create the scleral lake. Scleral lake, theoretically, 4 and 2 millimeter will be enough. But for challenging cases, I recommend the scleral lake more in size and more in depth. Some cases I'll use 4 and 2.6. And then the depth of the scleral lakes will be very thin, with very thin scleral floor, which I could see through the pigmentation of the ciliary body. And then in China, the fibrotic issue is very remarkable and very severe. So we use the anti-metabolic agent routinely. MMC or 5FU are both okay. And then we could just move on laser to ablate the outward Schlemm's canal. Schlemm's canal could also be removed in at least 1 and 4 millimeter. And then we recommend strongly about the ablation of the TDW area. It is called trabecular decimated window. So there are basically 3 advantages of the ablation of TDW. Firstly, it's potentially increase the percolation of the aqueous, increase the size, and it also potentially increase the size or volume of scleral lake. And most importantly, the creation of TDW could substantially increase the successfulness of later on LGP, the laser gonial puncture. Because laser gonial puncture is very useful and common adjunctive therapy, not only for class but also for NPDS. That could even furtherly facilitate the aqueous outflow. And then we'll have the closure of the flap, of course, but here I'd like to recommend the using of the adjustable suture to close the flap very tightly at the very beginning, and that could avoid the infiltration of the blood or inflammatory agent into the scleral lake. And later on, you can just remove the suture, and then you can potentially create the bleb as well.